So very good afternoon, everybody, and thank you, PCSI and Dr. Amitabh, especially for giving this important talk. The previous speaker has spoken everything about the fetal echocardiography, and everywhere there was a positive message that this is important investigation. It is a boon for the fetal heart and for the pediatric heart. So my talk at the last, Ucha has covered whatever the social issues related to fetal echocardiography, its implication on the pediatric point of view. So you can say it's just a revision about those in next 10-15 minutes. I'm going to discuss one, it is Boon, and for the Indian context. So these are the two aspects I'm going to cover. So starting with my index case, this is 27-year-old lady, gravida 4, para 1. There were 2 miscarriages in the first trimester, and those were not investigated for the cause of miscarriage. These were spontaneous. Only one live child who was healthy. Referred for fetal echocardiography as there was some detection of cardiac mass at 23 weeks of gestation. And this was the fetal echocardiogram. Showed multiple homogeneous hyperechoic avascular mass attached to basically mid and the apical ventricular septum. There were normal inflow and outflow tract. He was in regular baby was in regular rhythm. And with the diagnosis of rhabdomyoma with likely association of tuberous sclerosis. These were findings were made on fetal echocardiography reports. And because there was history of miscarriages, previous 2 miscarriages, counseling was done with the parents, and DNA analysis was performed which showed association with the tuberous sclerosis gene. This is autosomal dominant inheritance. This helped in 2 things. One is there was accurate fetal counseling and making the family aware of the lifelong implication of this genetic syndrome. This is an informed decision taken by the family, and they decided to continue the pregnancy. They understood and they decided to continue, and the decision was obviously well respected by all the by the team of doctors dealing with the lady. Same time, the family and the perinatal team was prepared, including the obs, neonatologists, cardiologists, and other caregiver about the high-risk pregnancy. So with this case in mind, we reviewed our cases of tuberous sclerosis. Main presentation was of rhabdomyoma, means cardiac mass in over that 1 decade. But over the subsequent time, skin changes, arrhythmias, neurological changes were last to appear in these patients. So counseling the family that cardiac mass, which is thought to be a benign lesion, is not always is benign, may increase in size, other changes may appear. So that counseling make a very important effect on these fetus parents about the future. Okay. The next lady is a 28 weeks gestation age, referred with the first miscarriage. It was second pregnancy. An indication of fetal echo was moderate TR and small pericardial effusion on antenatal ultrasound scan. If you look at the fetal echocardiography, this 4-chamber heart, dilated right side of the heart, with there is tricuspid regurgitation. Intracardiac structures was normal, heart otherwise was balanced, means there was no hypoplasia of other side of the heart, the connections was normal. With this tricuspid regurgitation, dilated RARV, and what was the culprit was a ductal restriction. History I could find that mother was on ecosprin and low molecular weight heparin, and she was positive for EPLA, and there was first miscarriage. So obviously, electively, she was put on 2 blood thinners, ecosprin and low molecular weight heparin. With this diagnosis, ecosprin was stopped. A detailed discussion happened with the family and the referring obstetrician. The low molecular weight heparin was continued, and it was very closely followed for the ductal flow. By 3rd day, stopping of the ecosprin, the flow became normal. And the only purpose was to find some days, some weeks, because it was 28 weeks. We want the fetus to go towards the maturity as much as possible with a close watch on the fetal heart. Fortunately, things happened, and it was continued towards that term and delivered by cesarean section at 38 weeks of gestation. Another case is a 36 weeks, gravida 2, referred. Indication was again cardiomegaly and tricuspid regurgitation. And here, the intracardiac echo was normal, connections were normal, right heart was dilated as in the previous echo, but ductus was severely restricted. It was 36 weeks of gestation, and with these findings, decided to go for the cesarean section. As expected, family, the baby had, because it was sort of acute shock for the fetus, means multi-organ dysfunction. We were expecting, and baby had decreased renal function, PPHN, which took around a week to stabilize. things happen in a very positive way, because things, his inotropic support, his respiratory support, everything was planned in view of this ductal restriction, effect on the lungs, effect on the other organ of the body, and the delivery and baby was discharged on 1 week of life. Then lots of structural issue we all have discussed, that all sort of CSTs, rhythm disorder, pericardial effusions, bradytachy, everything can be diagnosed by fetal echocardiography to make a very positive impact on the life of the fetus and the planning for the neonatal and the later life. So why this question? Is fetal echo a boon on brain? Why we are discussing this question? Whatever we have discussed, we know that this is going to have a positive impact. We are going to decide about whether the structural, if there is structural issues, if it is normal, this is very good. So there is family history of congenital heart defect. We do a detailed evaluation and find everything is normal. There's a positive impact on continuing the pregnancy, on the family, on the maternal mental health, and obviously for all the family members. If there is structural cardiac defect, if it is of same severity or it is stable defect, it is critical defect. So everything we can define by this fetal echocardiography by close monitoring of the fetal heart. A hemodynamic assessment. So not only the structural defect, with hemodynamic assessment is also important. This is the clinician. After birth, we do auscultation, we do clinical examination. But during fetal life, we have our Doppler to reach for the hemodynamic assessment. And this clinician approach helps us to guide to know, like the structural restriction it is a hemodynamic defect. It's not a structural issues, but we could salvage these babies, because that thinking from hemodynamic point of view is very important. If it is progressive lesion like mild aortic stenosis, may go to severe first or second degree heart block, which we have discussed in rhythm issues, suspicion of long QTC. So what is happening to these rhythm issues can also be followed according to that with a close watch. And if it is transient issues, which may be serious, your arrhythmia could be intermittent, transient, but may become serious. Your ductal restriction may become serious. Pericardial effusion, like Dr. Nageshwar have discussed effusion and causes of pericardial effusion, which can be dealt if you're thinking from the etiology point of view from that pericardial effusion. So fetal echocardiography is definitely going to have a positive. How we utilize it, that is important. When we are getting these ladies for fetal echocardiography, is important to help these families, because Boon only happens if we do things on a correct way and on a correct time. So this is my experience about the fetal echocardiography over the last 10 months. This is from the Government Medical College, and 234 ladies were referred for the fetal echocardiography. All were having an antenatal scan done within 2 weeks of referral. All were referred by obstetrician. I did not get the patient, the lady, directly from the obstetrician. This is the like sort of way here, the working, the obstetrician sent to a radiologist, and they send the patient to the obstetrician, and obstetrician decide whether they want a further investigation for that. Indication of referral were mainly fetal in 2/3 of cases. In around 1/4, it was maternal indications, and routine, like sort of Usha said, I want a perfect baby, evaluate everything. So these were the indications in 7% of patients. The commonest indication were echogenic nodule and the suspected heart disease on ultrasound scan. And another indication of history of miscarriage, that is 10%, another significant indication for referring for the fetal echocardiography. Overall maternal age was 28 years, mean age. Gestation age was mean 25, and gravida mainly were primary gravida. With the heart defect, whether this is ductal restriction or this is structural heart defect or arrhythmia, the mean age was around 27.5. Gestation age 26, and the gravida, again, it was primary gravida. So mainly primary gravida was so it is not that the multipara or it is previous history of heart defect or maternal issue with the culprit. So here anyone can be. So all fetus should be looked carefully by the ultrasonologist person to have a suspicion and refer the lady timely for the further work from the fetal cardiac point of view. So indication of referral wise, the fetal heart disease, suspected heart disease was the commonest indication after the echogenic nodule. And the sensitivity was very high, except one. All had heart defect, but severity of heart defect was definitely higher. They referred wise some discrepancy in size of heart, some discrepancy chamber size, some discrepancy in size of great vessels, or outflow not profiled well. And then there I find either it is tricuspid atresia, hypoplastic left heart, or coarctation setting, or ductal restriction. So these are the higher things we could find on fetal echocardiography. So definitely there was suspicion on routine scan, but on fetal echocardiography, because hemodynamic assessment was done there, we could give higher information and we could counsel the family in a better way. Rhythm abnormality, they wrote tachy or bradycardia, but we could confirm type of rhythm. And one of the patient who was referred for the fetal bradycardia had corrected TJ. It was the 2:1 AV conduction. Diabetes mellitus mothers, no significant anomaly was there except one small VSD. Previous history of CSD, which was a significant number, but in one, there was no critical, there was one small muscular VSD and another was having VSD pulmonary, the same as the previous baby was carrying. IVF, all were normal, pericardial effusion, two having the restriction, and one was having idiopathic arterial calcification. Echogenic nodule, all were same, means no significant heart disease in echogenic nodule mothers. So most form of congenital heart disease or cardiac involvement occurred in low-risk pregnancy. So as a rule, basic screening of fetal heart in all antenatal scans should be must, and fetal echo should be done if there is any suspicion from the radiologist or any history suggestive of that to the fetal echocardiography should be referred. So obviously this is Boon, and there are many studies from India. So special focus on the lower socioeconomic groups and Indian subcontinent.
Can we conclude?
Yeah. So there are many messages, there are many studies proving that about the positivity of the fetal echocardiography on the pediatric or the neonatal outcome of the only Bane which I see, which Usha also said, that too much discussion about the small muscular VSD, right aortic arch, aberrance of Cleveland, and isolated left testis. So these are the things, lot of discussion, especially upper socioeconomic status, while in the lower socioeconomic status, even a complex heart defects are not discussed. So this is the very negative part which need to have on same parity with whatever ground we are dealing with. The imposed limitation or because of less of awareness, and that is article from Narayana Hidale about hardly any awareness, even with the parents of the previous child with congenital heart defects. So awareness, timely referral, team discussion, all these things will make it better for the fetal echocardiography outcome. The take-off message is the fetal heart screening should be an integral part of antenatal screening in all pregnancies, because fetal heart disease is not limited to high-risk pregnancy. We have a unique opportunity at this point to diagnose and understand variants. A good multidisciplinary approach is very important to counsel about all the issues. We can improve the outcome if we discuss in detail, we counsel them in detail, and we can reduce the burden of complex heart disease if we get the fetal echocardiography evaluation on time. So by discussing all the options and obviously respecting the family decision if they want to continue or not to, but that option should be given. So to conclude, for any disease, prevention should be part of utmost importance. But like in congenital, we don't have that in our hand, we can't prevent. Then in this condition, honest guidance to avail best of available resources should be our only aim. Thank you.